I'm Wayne Fuqua. My last name is easily mispronounced and becomes obscene when mispronounced. You're certainly welcome to address me as Wayne. I'm not a very formal person about things like that. I'm a faculty member at Western Michigan University, and I'm a board-certified behavior analyst at the doctoral level. I will talk about evidence-based practice, and let me disclose that I'll use some examples out of behavior analysis or applied behavior analysis. But I would like to encourage or challenge all the participants to think about how the concepts that we talk about here apply to your particular discipline. So as we go through, feel free to offer comments, suggestions, examples out of your particular discipline as it applies to evidence-based practice. Okay, so let's move forward a little bit. Here are some module objectives that we'll try to accomplish. One of the first is I would like you to certainly be able to explain the critical features of evidence-based practice and be able to explain how that model goes beyond the slightly simpler and more constrained version, which is empirically supported treatments. And I'll explain that as we go along here. Then I'd like you to also be thinking about the ethical and practical rationale for evidence-based practice. And one of the assignments that you'll be asked to do is to go check out your own professional code of ethics and determine whether or not evidence-based practice, either in name or in concept, is referenced in your code of ethics and your professional practice expectations, and begin thinking about, well, how do you actually implement evidence-based practice in your own discipline? If indeed that evidence-based practice and its concepts are not referenced, then I'd like you to think a little bit like a leader and be thinking about, well, gosh, why is it not in our professional code of ethics, and should we at some point in the future begin to build in some expectations for evidence-based practice into your own discipline? Then in addition to that, we'll spend a little time talking about resources and practical steps to adopt evidence-based practice in your own discipline and practice. And this is one of those places where I will ask you to do some research in your own discipline to identify the best resources, or also to work with your mentors to identify the best resources, because they're going to vary from medicine to psychology to social work to nursing to speech and language, a range of different places you'll find these sorts of empirically supported treatments and resources along those lines. So I'll ask you to think about how they apply to your own discipline. Then we're going to do a little exercise in this later on. Many of you, especially those that are practitioners, will at some point in your practice be faced with requests from some of your clients to try out what I'm going to call fad treatments, treatments that may or may not have any adequate evidence to suggest that they would be effective. And we're going to do a little exercise later on to help you decide how you would like to respond to that type of request. So let me start with a question first. This is a probe question for trainees. Which of the following is not a component of evidence-based practice? Treatment based on best available evidence, ongoing clinical progress monitoring, treatment adjusted to reflect patient values, treatment selected to reflect the clinical expertise of the service provider, or all of the above are components of EBP. Okay, we have everybody finished?
Yes.
More or less? Great. Okay, so the correct answer, the best answer to this would be all of the above components of evidence-based practice. So to the 56% that got that, congratulations. I would say you're finished for the evening, but most of you do know that a simple recognition multiple choice test is the lowest level of Bloom's taxonomy, so we're going to go beyond that and do some thinking about, well, why are some of these other components actually important components of evidence-based practice, and how do you actually implement and include some of those in what you're doing? So there is room here for, obviously, for people to have some improvement here. Let's see if I can get my cursor to move us forward. There we are. Did anybody, by the way, want to offer any rationale? This is a chance to offer a comment also as to why you selected one of the items.
Hi, Wayne. I have a kind of question of why D is not the correct answer. So in my mind, I was thinking, as an audiologist, if I have two potential treatment options, but I'm more versed in one over the other, then selecting that option just because I'm more versed in that isn't necessarily following the components of EBP?
That's an excellent question, Renee. And the answer to that, when you take a look at the model, is that when you have a choice of more than one empirically supported treatment, now that's a critical dimension right there. You have to have a choice of more than one empirically supported treatment. Then a whole range of other factors can come into effect. One of which is, of course, patient values. The other, of course, is what expertise and scope of competence the clinician might indeed have. And that's clearly recognized as one of the driving forces in evidence-based practice. I would also point out, though, to kind of justify, or at least also point out that there's some rationale for what you said, that one of the challenges for clinicians is to make sure they have competence in a full range of interventions that would fall into the category of empirically supported treatment. So if there was going to be one that would be not a component, that's the closest, but I think that the best answer, and we'll see in a few minutes, is that all of the components are considered to be parts and parcel of evidence-based practice. But as your point is an excellent point, Sinead. Any other comments before I move on this one?
So, hi Wayne. Thank you for this wonderful talk. In audiology, a lot of times we're confronted with areas of practice for which there is not good evidence. So it'd be nice if you could do in that case.
Okay, you cut out a little bit, Janie. I think what you're asking is, can we talk about situations where you don't have strong empirically supported practices on which you can draw? Is that what you're asking?
Yes.
Absolutely. And let me go to that in just a second here, okay? I think it's going to be covered in this next slide. And I will be the first to say, take what we're talking about here and extrapolate it to your discipline, because different disciplines are going to have different standards for empirically supported treatment.
I don't know what we do.
Okay? So let me see if this next part answers it a little bit. So evidence-based practice in general is a clinical decision-making model. And we think that it applies across different disciplines to different degrees. Let me acknowledge that it was originally developed in the medical area by Sackett back in 1997, and he now has multiple revisions of this book called Evidence-Based Medicine, How to Practice and Teach EBM, and it continues to evolve and develop. So that's where the original concepts came from, but it's really not a new concept because many of the disciplines that are clinical have some connection with some sort of underlying empirical supported treatments. And as I mentioned before, it does have some level of applicability, though it requires translation work. In nursing and dentistry, you can see a whole range of other areas where the concepts have been applied, once again, with varying levels of extrapolation needed in each one of these areas. I know we have a few people in here that have a behavior analytic background. It's recently been applied in behavior analysis, and one of the suggested readings is of an article out of 2014 that talks about applied behavior analysis and evidence-based practice. One thing I would mention for those that have a behavior analytic perspective is that you might say, well, why did it take so long to actually show up and apply behavior analysis? Well, in reality, the original founding principles of applied behavior analysis included some discussion about effectiveness, generalizability. So in some ways, it's been present all along, but now we're beginning to talk about the more general principles and how they apply. So my challenge for everybody here is to think about, well, how do the concepts elaborate onto and kind of connect in with your particular discipline? So here are the essential ingredients that people tend to point to when they're talking about evidence-based practice. And Janie, this relates to your first comment here. And what we're talking about originally here is that you try to do clinical delivery of services based on the best available evidence. And in different disciplines, that's going to differ from discipline to discipline. Some disciplines have exceedingly well-developed and researched and replicated practices, others not quite as much. So it will be something that you have to think about how it applies to your particular discipline. Those best available evidences that the research would typically be called empirically supported treatments. Then there's agreement that you need to think about the clinical experience, judgment, and competence of the practitioner. And as I mentioned before in response to a different question, sometimes you have practitioners that can identify a range of different treatments that have some reasonable evidentiary support, but the person has a lot of experience in one versus the other, so that would then end up being the treatment of choice if all other things are equal. Now, I will be the first to admit that very seldom are all of the things equal, but nevertheless, that's one of the principles that is to be considered as you're making some clinical decisions here. And we'll elaborate on this in just a minute, but also patient values and preferences. Identifying a range of evidence-supported interventions and getting input from the patients about which intervention is most compatible with their beliefs, their ability to help participate in the intervention. And then we'll talk about contextual features. There's some situations where an intervention may take a lot of resource and sometimes highly skilled people to do it. There's other situations where you don't have access to those people, that type of resource, or people with the same set of skills, and you have to then adjust your selection of treatment strategies. And then the last thing I'll mention, and we'll come and elaborate on this a little bit, is some sort of ongoing clinical progress monitoring and adjusting treatment. And in many ways, this is taking the parallel to what Jane talked about in quality improvement cycle, but applying it to interventions that are designed to improve symptoms, behaviors, medical conditions, and ultimately, and this is the really critical ultimate, quality of life and functionality for some of the folks that we might be working with. So those would be some of the things to think about as we're moving along these lines. Let me say a couple things about why we think evidence-based practice is important. One of them is we have a fair amount of research out of a number of different disciplines to suggest that you can probably improve clinical outcomes if you do some efforts to identify empirical research and make decisions that kind of are drawing from that empirical research. And we oftentimes will call this the research to practice gap, and most of our disciplines are going to have a research arm, and one of the real challenges is how do you get practitioners, the people that are out there taking that discipline and using it to improve people's lives, how do you get them to base their practice on some of the research advances? And that's sometimes a challenge, but the evidence-based practice model asks the practitioner to go back and look at best available evidence. And sometimes that best available evidence is not perfect, but it's at least evidence that suggests something might work. So that's one of the factors that would suggest is important. The other thing that I'd also mention only very briefly here is that the research to practice gap goes the other way too. And that is that sometimes we want to take things that are practices that we think might be effective and make sure they really are indeed effective. So it encourages people to do empirical research on what they think to be the best practices that you've developed in your discipline and verify that they really are working to the degree that you think they are, so that they can help you and your clients, but also other practitioners within your discipline. So you have two sides of the coin in this particular occasion right here. The other thing that I would point out is that the rationale for evidence-based practice, especially if you begin talking about the medical rationale, I've found it to be very persuasive for most audiences. And if you raise the question about, you have some sort of illness or some sort of disease, would you prefer to go to a physician that says, okay, let's do this treatment, it looks like it's been researched and looks like it's going to be effective for solving your problem, or would you prefer to go to a physician that says, I have no idea whether this works or not, let's just try it out. So most people find it very persuasive to say, gosh, let's take that persuasive argument in medicine and apply it within a discipline so that you can encourage people to pursue evidence-based practices within each of the disciplines where that model might be applicable. And finally, I'll mention briefly that in most states that have adopted, and I'll use autism, by the way, in some of my examples because that's the more prevalent of some of the neurodevelopmental disorders that we're going to be talking about. But in autism, the mandate that requires that insurance companies and Medicaid cover autism services makes reference to evidence-based treatment. And you'll find that across a large number of states. I think there's something like 43 states now that have passed autism and insurance reform, and most of them make some reference to providing services and reimbursement for evidence-based treatment. So there's a mandate for making sure that people do that. One other rationale for evidence-based practice, and that is that I would encourage all of the trainees to do a little looking within your own discipline to determine if you have a set of professional guidelines, an ethics code, and scan that enough to determine whether or not it mentions evidence-based practice either in name or in concept. Many of them will, certainly medicine, and certainly at least in psychology and behavior analysis it does mention it. I will leave it to you to determine whether or not your particular discipline does mention some variation on being effective, beneficence, some sort of connections with evidence-based practice. To give you one example, here are some materials out of the Behavior Analysis Certification Board Professional and Ethical Compliance Code, and just to give you a sense of what some people sometimes write into codes, clients have a right to effective treatment, more specifically, based on the research literature and adapted to the individual client. So you can see that that's clearly written into the ethics code for behavior analysts. Similar things are written into the ethics code for psychology. Here's one other example just to get a sense of it, and this elaborates a little bit on the evidence-based practice model in those instances where more than one scientifically supported treatment has been established. Additional factors may be considered in selecting interventions, including but not limited to efficiency and cost effectiveness, risks and side effects of the interventions, client preference, and practitioner experience and training. Now, one of the reasons I have this up here is because all these other factors that are listed down in this part here, all these other things that are listed, those are thought to be factors that should help us select when there is more than one reasonably supported, best available evidence intervention that's out there, and you're trying to choose between those interventions. These typically are not thought to be things that would then preempt focusing on an evidence-based practice or empirically supported intervention. In other words, you wouldn't be choosing something that's ineffective and not tested and potentially dangerous just because you client preference or practitioner experience. So those are some of the factors that are typically considered, and once again I want to emphasize I'm just using this particular code of ethics as one example, and would like to simply encourage you to take a look at your own professional discipline and ask if your code of ethics has something analogous to this. And by the way, if it doesn't, many of the trainees and the mentors have roles as leaders. You might want to ask yourself, well, should we think along the lines of expanding our code of ethics and our professional ethics expectations to include things of this nature? Hopefully, what we've talked about thus far suggests that evidence-based practice is a pretty helpful concept for clinical practice and fairly persuasive. It would be nice to say it's easy to do, but it's not always easy to do. And I said right here, practicing evidence-based practice takes practice. And let me point out some of the challenges for practitioners, and we'll talk about how you get around some of those challenges as we proceed. One of them is, how do you actually identify and select empirically supported treatments for medical conditions and behavioral problems? In just a minute we'll talk a little bit about some of the search strategies you might use and how to evaluate interventions, and what to do if you can't find a strongly supported, empirically supported treatment. Where do you go from then? Do you just throw up your hands? And the answer is no, you don't. How do you then individualize treatments for specific clients and contexts? This is not cookie-cutter practice or cookie-cutter medicine. This is really, how do you take individual differences and understand how those might have an impact on selecting and implementing different treatments. Talking a little bit also about practitioner competence to implement evidence-based practice. In many of our disciplines, there are so many empirically supported treatments that it's virtually impossible for one practitioner to be thoroughly competent and confident in implementing every one of those. So then the question becomes one of, well, how do you either improve your range of competence, or when do you make decisions to refer to another person who has greater competence in this particular intervention or treatment? Then assessing clinical response to the treatment, and once again it goes back to what Jane was talking about, monitoring response to any sort of intervention and deciding if you're going in the right direction, improving things, or going in the wrong direction. That's a critical component of evidence-based practice. And it relates to the next thing I'll talk about briefly here. I would like to dissuade all of us from thinking that everything we do in treatment is always going to be successful. You know, it's simply not the case. I mean, we just have lots of individual variability, lots of sources where things can go wrong, and part of our job, I think, as practitioners is to think about how do we detect any treatment failures, people that are not responding, or people that are responding adversely to the efforts we're making to improve their condition. And then how do you go about troubleshooting those treatment failures? So those are some of the things we'll talk about briefly. And then we'll talk a little bit about how to respond to requests for FAD treatments and others that fail to meet evidence-based practice standards. So those are some of the components there. I won't talk about this last one in much detail, but if you want to have discussion about it, I'm very happy to talk about it. And that is, we might want to think about, if you like the evidence-based practice model, how do you begin to promote it and disseminate it within your particular profession? So I'm going to move us on a little bit and talk a little bit about the criteria for empirically supported treatments. And I'll refer to psychology for now, but once again, recognize that there's also different standards and criteria that apply to audiology, speech and language, and medicine. Here's the classic reference for evidence-supported, empirically supported treatments in psychology. It's the Chambliss article in 1998. They talk about the different criteria, and I'm going to mention them briefly because these criteria, to a certain degree, are replicated with variations in different disciplines. First, there was a suggestion that we need to have two group comparison designs, oftentimes referred to as randomized clinical trials or randomized control trials, or a series of, and I put it here, single case studies. They aren't really single case studies. They really are studies that oftentimes will do multiple measures focusing on a single person over a period of time, testing them out under baseline, no intervention conditions versus intervention conditions. I can elaborate on that further if you'd like me to, but the bottom line is you need to either have two group designs or a whole series of single case studies that shows that the treatment is equal or superior to, as I say here, a pill, placebo, or some other accepted treatment. If it's not superior, but it's only equivalent to an already established treatment, that can still be valuable too. And the question then becomes one of, well, if it's equal to an already established treatment, is it more efficient? Perhaps less costly? Perhaps it has fewer risks, fewer side effects? Many people would argue that, gosh, if you can develop interventions that have a more efficient, less costly, fewer risks, and fewer side effects than the existing interventions, then that's a major advance also. So those are some of the criteria. Now there's another set of criteria that's also worth thinking about, and because it ties into clinical replication, and that is Chambliss et al. Suggests there needs to be something like a treatment manual, either a treatment checklist or a manual that would allow practitioners to fully replicate the essential components of the treatment when they're out in the field working with clients. So that's another component that needs to be there. It doesn't matter how well we've done the research if no one can replicate and reproduce the procedures out in the field and get similar results, then it's of limited utility. There's also the requirement that the client characteristics are specified, so you'll typically be able to see, you know, how many males, how many females, what ages, what diagnostic categories would it apply to, because part of your challenge as a practitioner is you have to decide, do these empirically supported treatments that you're looking at Do they apply to specific clients that happen to walk into your office and or into your practice? And we'll talk a little bit about that in a few minutes. And then you typically have to have evidence from 2 or more independent practitioners or independent research groups to make sure there's not potential for bias in terms of how you're getting the results, that sort of thing. Let me talk long enough to see if these are fairly clear or if anybody has any other questions or comments at this particular stage. Hearing none, let's move on a little bit. Then the question becomes one of, and I'm sorry I have the wrong acronym here, I need to change that. How do you identify and apply empirically supported treatments? So this gets to be, well, the practical aspects of it. Well, anytime you ask people, how do you do something, or ask for knowledge, everybody says, well, you do a Google search. Well, that's okay, but here's the problem with Google. If you do a Google search on something like pica, most of you know that's eating inedible objects. It's just sometimes a problem for people with neurodevelopmental intellectual disabilities, and evidence-based treatment. That search returns 422,000 hits. A lot of those are ads, many of them are questionable utility, and I don't know what your work week looks like, but I don't have time to look through 422,000 separate returns on a Google search. Just not practical. So he said, well, let's make it a little more refined. For those of you familiar with it, Google also has a Google Scholar section. If you just type in scholar.google.com, you get to that. But that also returns 36,000 hits. So these are starting points. They certainly give you a hint in the right direction, but you can't be thorough in looking at all of those materials there. And then one of the other problems, of course, is that you still need to evaluate oftentimes each of the original articles in terms of the quality of research, the relevance. I would like you to think that everything that's published is high quality, but it's not always high quality. So absent that, what else might you consider doing to help you to identify evidence-based interventions here? In your discipline, you might begin looking at different texts. And there are some increasing number of texts that are out there that do reviews for you on evidence-based practice. I have an example that I've used in a course right here, and it has chapters on coping with language deficits, coping with stereotypy, coping with aggressive behavior. So those are a step in the right direction. But there is a problem with books that I suspect everybody knows, and that is by the time they're available on the shelf, they're oftentimes a little bit out of date. So this is a recent publication right here by Sturmey and Diden, but the chapters I know were written 5 years ago. So do recognize that the texts are a step in the right direction. They'll give you a hint, but they aren't always the sole thing that you need. I do recommend that if you can find review articles and review sources, including meta-analyses, those are good starting points. Now, if you type in your Google search or your library searches, review articles on pica and evidence-based treatment, you get a much smaller sampling, and you can begin looking at those review articles. So those are steps in the right direction. Here's a couple steps that are maybe in the wrong direction. Gosh, going to conferences, I love going to conferences. It's a great way to network, great way to see what's happening, but oftentimes there's very few conference presentations, and there are exceptions, of course, that provide you a thorough overview of evidence-based practice on a particular problem or challenging area. So conferences, take those with a little bit of a grain of salt. Sometimes you get great presentations, sometimes you don't. So that would be one of the considerations there. Mentors and supervisors, we're all knowledgeable, wonderful people. I hope we are anyhow, but even your mentors and supervisors, they probably don't know everything there is to know, so do recognize that you may have to supplement above and beyond the advice of the mentors and supervisors. One other challenge with all of this is that you're still going to need some guidelines on how you go about implementing a treatment. For those of you who have ever read an original empirical study, and I've read hundreds of them over the course of my lifetime, even reading the methods section very seldom gives you enough detailed information that will allow you to actually implement the correct details of an intervention, and in particular with a particular client you're working with. So you sometimes have to supplement that. Now, I don't have it here on the textual material, but there's a couple ways people have supplemented that. Increasingly, some of the journal articles are having people put online a treatment guide. Here's a checklist of what we actually did to implement a treatment. They don't have that detail in the publication because oftentimes they have page limits in publications. So that's one other supplemental source that's out there. And then the other thing that I've seen that's really quite interesting, and I don't have it here, is there are increasingly journals that are including video demonstrations of methodologies, treatment techniques, so that people can actually look at a video of how an intervention was actually done. And the one that I'm most familiar with is a journal called the Journal of Visualized Experimentation, JOVE, Journal of Visualized Experimentation, which unfortunately costs you a lot of money to publish something there because it actually publishes a video demonstration of an intervention that you've done, and it cuts across different disciplines. But as they say, a picture, or in this case, maybe a video, may be worth 1,000 words in terms of how you actually do something. So these are places to help you identify evidence-supported treatments, but you still need to think along the lines of how do you actually implement those treatments. The last thing I'll mention here, and I'm going to once again encourage you to think about how this maps onto your own discipline, is increasingly people are coming up with comprehensive independent reviews of the research. And in the medicine area, and Jane and some of the other folks in medicine will be able to elaborate on this, things like the Cochrane Collaborative and some of the resources that are out there to help physicians identify empirically supported treatments and evidence-based practices. Those are very, very helpful. Now, in the psychology and autism area, let me put in a brief plug for two different resources. One of them is the Autism National Standards Project, and the other is the National Professional Development Center project, both of which have done comprehensive reviews of interventions that are used to treat various aspects of autism and hopefully improve clinical, social, and quality of life outcomes. So those are very helpful resources, and they do a couple things. They're pretty clear about what kind of inclusion criteria they have in the research they're going to do and include in their comprehensive reviews. They will oftentimes go and give us scientific merit ratings because, you know, there's some research that you want to put a lot of credence in, and there's some research where you go, not so hot, but it still adds a little something to your understanding of a particular intervention. Those are some of the things they look at in their scientific merit rating. And they typically will classify, at least in the National Autism Center, effects in terms of beneficial, unknown, ineffective, and adverse. So this can be a helpful starting point to help people identify what types of interventions might be effective. It does have some limits in that oftentimes you're talking about broad treatment categories, you know, social skills in the autism area, for example. That's pretty broad. You can oftentimes be much more specific about the types of social problems that people are having. Is it a, you know, lack of eye contact, or is it a really awkward social interactions? So you sometimes are left wanting for a little more specificity, but nevertheless, it's a really good start for people to begin thinking about, well, what interventions look like they might work well or not work well. So here's my next trainee question. We've talked a little bit about how you identify them and where you go, how you do searches for empirically supported treatment. So the question that I would ask is, once an empirically supported treatment for a behavioral or medical condition has been identified through research, practitioners can have great confidence that the treatment will produce the promised benefits for each and every client. So the poll is true or false. And be prepared to justify your answer. So Mike, if you can put up the poll for that one, that'd be helpful. So everybody should be responding, and Mike will, oh, hey, you guys got it. Okay. Let me simply pose this as a question, and that's the correct answer. The question that I pose is, why is it false? Someone tell me why You simply can't just take an empirically supported treatment and apply it and get the promised results each and every time. Why not? Is it you don't trust the science? Yeah.
I think the biggest issue is, transference from efficacious-based treatment to effective-based treatments, and transporting from the lab to the real world, and passing the ecological or external validity test stands in the way as a major reason why you can't have that ultimate confidence.
Right, and that's a really good point, Ramsey. And let me elaborate on that just a little bit. A lot of these studies were done under, maybe not, sometimes they're done under lab conditions. Sometimes they're done with lots and lots of resources to make sure that you have all the components of the study done correctly and all the measurement done correctly. And I think part of what you're saying is that the real world is not that resource friendly, and it's much more complicated sometimes than the test or lab conditions. So sometimes those things get in the way of producing the exact same result you'd like to get out of the research. Is that a fair synopsis, you think, Ramsey?
Yep.
Okay.
That's a good one.
Yeah. Anybody else want to add in something to it?
Yeah, the one thing I think about is a lot of research that I see and we look at, especially in psychiatry, a lot of conditions are selected out. So sometimes the results just aren't generalizable to actual patients we see.
And you're absolutely right, Erica. Part of our problem here is, remember, as part of the requirements, you're supposed to identify your client population. But, sometimes the people that show up for services don't match up perfectly with that client population from the research. And you're always having to ask yourself, well, do the research findings really extrapolate to these particular people I'm working with? And, real life is much more complicated sometimes than the relatively homogeneous selection that sometimes goes into putting together a research sample. So you're absolutely right. And the question is, how then do you extrapolate, or how do you adapt, essentially? So there's actually lots of reasons why this is a challenge here, and Erica and Ramsey are both right on target in terms of some of the challenges. Let me see if I can elaborate just a little bit on some of those challenges further. Here's one of the challenges. If you're a practitioner, you're going to treat individuals. You aren't treating groups of people. And one challenge is relying on randomized control trials is, remember what they do is they accumulate 30, 50, 5,000, if you're dealing with a really big trial of individuals, into a treatment condition and into a comparison control condition, and you take the average performers in your treatment condition, compare it with the average of performers in the control condition, and of course if that difference is large enough to be highly improbable based just on chance, and those who've done inferential statistics, you recognize what I'm talking about, then you conclude that yes, my intervention really produced the effect with some certainty here. But the problem here is that individual variability may be hidden in group averages. And even if you have a big change in your average performance compared to treatment versus, non-treatment, even in those treatment people, there's going to be non-responders. There's going to be dropouts. There may even be adverse responders in there. So one of the challenges is recognizing there's no such thing as an average responder. So the people that walk into your office could be non-responders, they could be outliers, they could be adverse responders. And part of your challenge right here is to treat everyone as a potential outlier, which means that you start with this information and then you say, okay, how do I adapt it to best meet the needs of the person that I'm working with? And then how do I monitor hopefully a beneficial clinical response to the intervention that I'm doing? So this is one of the challenges we experience with just about any of the research, and that is where is the inference appropriate? Is it from the research sample to the larger population? That's appropriate. But from the research sample to specific individuals, that presents some challenges right there. So that's one of the challenges there. The other one that I'll mention only very briefly, and it's kind of an interesting topic, is that increasingly there's writing going on about replication failures in medical research. Now, I don't want to pick on medical research because replication failures occur across a range of different disciplines. And but this is an interesting book because they point out, you know, all these different things that we thought we knew at one point in time. Estrogen replacement therapy is really good, and then we discover later on, wait a minute, we're getting all kind of adverse effects from this, and it applies to medications, it applies to different sorts of interventions in the medical arena, and they point out that, you know, there's a lot of reasons why we have difficulty replicating medical research. I won't elaborate on that, but if you're interested in the topic, I would recommend this particular book to you. It's kind of an interesting book, and it helps you also understand, if you are interested in the research side of it, how do you improve the reliability of some of the research that comes out of medical research and the psychology and social work research. The other thing to point out is that we seldom publish treatment failures. You know, I've always joked that if we publish a lot of treatment, if we have, you know, journals that publish treatment failures, that have a lot more publications. But the truth is that we don't publish treatment failures because oftentimes the editors are looking for the neatest, most important advance. But I would argue that sometimes discovering that what we thought worked doesn't work very well or has some constraints on how it works. That's a really important bit of information. So publishing treatment failures probably is important, especially if you then say, here's what we then did to turn this treatment failure into a treatment success. And just a commentary here for all of us, be humble regarding what we know and how well we know it. One of my favorite sayings is by, it's attributed by the name of Josh Billings, and he has a variation of this that goes something like, it's not what we know that gets us in trouble, it's what we know that ain't quite so. So being confident in something and then discovering, whoops, that doesn't quite work, that's where we sometimes find ourselves getting in trouble. So more challenges. Remember, when you do look at this research that you might be looking at, you got, you know, some empirical research, and can you extrapolate from that empirical research to specific clients you're working with? And to a certain degree, the question is, how much difference is okay versus how much is not okay? So to get you to thinking about this, let me point out some things that may be trivial. Well, hold on now, I got off my cycle here a little bit, but here's some of the other challenges right here that I'll mention briefly. Considering client values and preferences, hopefully adjusting your treatments to deal with that. Training and competence of the treatment agents. And by the way, when I have treatment agents, I'm thinking here about physicians, behavior analysts, speech and language pathologists, but also thinking along the lines of teachers, parents, siblings, because depending on how much is involved with a family, they're oftentimes part of your treatment team. So you may need to think along the lines of, how do we identify and apply those effective treatments with a whole range of people that can be functioning as treatment agents sometimes. Contextual constraints, selecting ecologically valid target behaviors and treatments. I see this happen oftentimes, by the way. I sometimes do reviews for insurance companies of treatment plans, and I see people doing home-based therapy where the real problem is in the school, or the real problem is interactions with peers that the person needs some work on, and there's no peers at home. So you need to ask yourself something about, well, gosh, do I have the right context for an ecologically valid application? So you may need to make special arrangements along those lines. Cost considerations certainly are relevant here. Potential for harm and misuse is worthy of also considering. One other thing I'll mention, only very briefly just for thought, is that we're oftentimes working in a context where there's a lot of implementation and dissemination, sometimes prior to adequate testing. And if you've ever taken a look at what happens with the Food and Drug Administration's review and approval cycle for new medications, it would be interesting to ask ourselves, should we adopt something that looks like that? So before pharmacies, Pfizer or Merck or somebody can start selling a medication, It has to be fully tested. You have to do something about the abuse profile, the chances for side effects. It'll be interesting to begin asking ourselves, should we have a similar sort of standard before we start applying interventions to improve the quality of life for people with neurodevelopmental disorders, some sort of testing and review process. So now here's the next question for you. Once again, getting at what is an evidence-based treatment for a child with autism? Which of the following would constitute evidence-based treatment for a child with autism? A mom tells you that a new therapy works really well for her child and that you should try it with your clients. B, an established intervention from the National Autism Center's Standards Project. C, a therapy featured in both MSN and ABC as being effective. D, therapies that you identify from a Google search on effective treatments for autism. And E, therapy that makes sense based on well-accepted theory. So how would you respond to that one? In other words, the issue is what constitutes evidence-based intervention? You guys are good. So some people must have answered more than one, but I would agree that an established intervention from the National Autism Center, which once again has standards for the review and is done with an unbiased fashion, is typically the case. Sometimes you can get autism therapies from a Google search, but remember you still have to search through all the things that are paid advertisements and still make some judgment about whether the interventions that you run across with a Google search are indeed effective. And then the last one, maybe. I would like to simply point out that we have an interesting history in our country, or actually in the mental health arena, of sometimes doing things based on well-accepted theory, things that seem to make sense. And they turn out to be harmful. Sometimes they turn out to be ineffective. And if you go back and just look at the history of how we have historically understood and dealt with mental illness and behavioral problems, at the time that people were sometimes doing some of these things that include things such as bleeding or doing water purges, or even something called trephining. For those who don't know, that means you're cutting a hole in somebody's head. Those made sense because they thought at that time that it was well accepted that evil spirits that had infested a person's head or it had polluted a person's body and their blood had indeed been the cause of some of these problems, and therefore the thing to do is to let the blood out, or to cut a hole in the head to let a person's evil spirits get out. So I mention that not because I want anybody to think that we're doing awful things now, but to simply suggest we do want to be just a little bit skeptical about things that are based solely on theory until they've actually been subject to some sort of empirical testing. If anyone is interested in this particular topic, I would recommend a book to you by a guy named Robert Whitaker. It's called Mad in America, and he goes through some of the different therapies we've done and points out that sometimes we need to have better science before we know what really works and what doesn't work. So, but most of you folks were right on target in terms of the looking at some of the systematic reviews. Okay, looking at our time here, let me kind of press forward a little bit and talk about a couple of things here. I was started to talk about this earlier. I got out of sequence a little bit, but one of the questions is, how much can you extrapolate from research to a particular client? And I'd like to point out that some client factors are more relevant than others. For example, eye color. You know, if you did a piece of research, or you looked at a piece of research and said, you know, we were working with people with blue eyes, and you have a client with brown eyes, and I'm doing this for intent here. Can you extrapolate? The answer is probably yes. That seems like a relatively trivial distinction right here, unless, of course, you are an ophthalmologist where indeed the color of the iris or the color of the eye might make a big difference in terms of the level of sunglass shade you needed or something like that. But you know, eye color is probably not a big issue, though it could be made a big issue. Just to remind you, Jane Elliott, for those who don't remember or don't know, she was a school teacher in Iowa. On the day after Martin Luther King was assassinated, she went into her classroom, I think it was a 4th grade classroom, of all Caucasian white kids, and wanted them to experience the issues with discrimination. And she got into her class and announced to the class, by the way, I just read this wonderful piece of research suggesting that people with blue eyes are intellectually and socially superior to people with brown eyes, and gave everybody with blue eyes a special ribbon to wear that got them to the front of the line, got them extra recess, and the people with brown eyes, as you could well imagine, were distraught, being discriminated against based on that. And of course, she came back the very next day and said, oh my gosh, I'm so sorry, I made a mistake. I misread the article, and it's really people with brown eyes that are intellectually and socially superior. So she flipped the discrimination around. And the only reason I'm mentioning this is because sometimes characteristics have social importance or expectations and discrimination associated with it that may make it an active intervention or active kind of trait characteristic that needs to be considered. But now there's others that are also important too. Age, for example. If you're working with a client, you know there's a 3-year-old child, and the research that's been done has been on the 8, 9, and 10-year-old children. Well, you know, that may be a big enough difference because there's different developmental milestones that have been reached for 8 versus 9 versus the 3-year-old child you're working with that may make a difference. And by the way, you're going to have to use clinical judgment right here, because the difference between a 3-year-old versus a 9-year-old child, that's a 6-year difference, may not be significant if it's between a 50-year-old person in a piece of research and a 56-year-old client in your office. So do recognize that there are some situations where age, you just can't take the absolute number and extrapolate. You have to ask, what is there about age that would be an important difference? And I would say that the same thing goes with respect to gender, ethnicity, religion, diagnostic labels, that you need to do some judgment about how are these trait characteristics, these client characteristics important. How do I take them? Being aware of them is really, really important. And by the way, Denise White Perkins did a great job helping us understand how some of these characteristics are important. But I would suggest let's go beyond just awareness. Let's begin asking ourselves, how do you take these things into account as it applies to your practice? The other thing I'd like to also encourage us to do is to you know, if you have males versus females, remember that not all females have the same values or the same goals. Not all Muslims have the same beliefs and same values. Recognize that we need to then extrapolate this as a starting point, think along the lines of how does this all apply to individuals. So those are some things to consider. And how do they impact things? Well, they're certainly going to have an impact on the language and communication we use. Thinking along the lines of how do you talk to people, what language, what words do you use? Those are important. They will certainly have an impact on the behaviors and the goals that are valued and reinforced. Those are oftentimes very individual and individualized, and they have sometimes links to ethnicity, religion, SES, whole range of things of that nature. They will sometimes impact which treatments are acceptable. For example, what roles do the parents have? Some parents have a very active role in different societies. Some people have more hands-off roles. So you need to think a little bit along the lines of how do all these different characteristics play into the design and delivery of services you might do. I would point out that it's certainly okay to ask about cultural factors or to observe them. Those are important. The other thing I would point out, that just for thought here, is that I think it's really important that we spend some time understanding client values and how they influence our delivery of services. But do recognize you may need to think along the lines of whether you have some ethical limitations on simply accepting client values. Is it okay to refuse treatment or service based on questionable client goals? I've certainly been in situations where a client wanted to use corporal punishment, that is to physically punish their child. And I go, well, I'm not quite so sure that I would buy into that. Let's come up with an alternative to that. So do recognize that you may sometimes have to say, I'm sensitive to client values, sensitive to client characteristics, but there are some things where you simply have to draw the line and recognize your client is oftentimes the child or the person with disabilities, and you want to be sensitive to the family concerns, but sometimes you may not be able to be completely responsive to those concerns. I would also point out that sometimes it's okay to nudge client values. And let me give you an example of that just so you get a sense of what I'm talking about. I spent a year at Johns Hopkins working in the Kennedy Krieger Institute. And that institute sees all kind of really challenging behavior problems with people from a full range of disabilities. And we had a woman come in who had just adopted a child. She was a professional woman in her 40s and decided to adopt a child. And she came in saying, my child, something is wrong with my child. He misbehaves. He's terrible. I'm thinking about turning him back over to the adoption agency. So we were thinking, oh my gosh, what's going on right here? And we took a look at the child, and he was pretty active. Remember, we'd seen all kind of behavior problems, but he didn't seem to rise to the level of being a problem that we just needed to have this woman turn this child back over to the adoption agency. So what we did to nudge her client values is we gave her a homework assignment. We said, we'd like you to get a babysitter next Saturday, and from 2 to 4 o'clock get the babysitter, and your job is to go to a park in your neighborhood and sit in that park and simply observe the children in the park. And she did that, much to her credit, and she came back the next week and she essentially said, oh my gosh, you will not believe all the misbehaving kids that are in my neighborhood. She essentially had seen that, yeah, what I was observing in my own child is not way out of line. It's not unmanageable. It's not some indication that this is unacceptable behavior. So in some situations, you may need to think along the lines of, can you nudge your clients towards a more realistic set of values and set of goals? So those would be things to kind of do advisedly, but once again, recognize that those are some considerations too. I'm going to skip through some of the stuff very quickly here. I know we have about 8 minutes left, and that is you want to match certainly the treatment to the context. That's one of the other things you do in evidence-based practice. And by the way, I would point out here once again that some skills and treatments simply don't match well to a specific treatment context. You may have to think along the lines of how do you apply treatment in the clinic or the school or the community. So you need to match the treatment with the context as best as possible. And I'm skimming through this, recognizing that if you need me to come back and talk about them later on, I certainly can, but we're running out of time today. Then the last thing, not last thing, but another thing I'll point out is that you then have the challenge of how do you go about implementing evidence-based practices. And increasingly you're going to find checklists and treatment guidelines that are available. The other thing that I would point out is that increasingly you're going to find videos of therapy being applied or simulated. When I'm talking about simulated, I'm talking about you're taking a make-believe client but showing how the therapy would be done. If you're interested in that, there's several resources right here. You can see what they are, and I'll also put in a shameless plug here for looking at the Autism Center of Excellence resources at WMU for a series of videos, and here are the topics for those videos. And by the way, notice that they are free of charge, okay? So I'm certainly getting no benefit, and Western does not either. But you can see some of the different types of interventions that we have demonstrated with people that are recognized national leaders in some of these particular areas. So if you're interested, go take a look at that, okay? I'm going to skip over the stuff on treatment failure, and I'm going to move forward and do one more thing here. Now, I apologize for zipping through all this stuff really quickly here, but I do want to get to one more thing just in way of a demonstration. For this demonstration, and we'll do it really quickly here. I would need one of the trainees to volunteer. And what we'll do is we'll unmute your mic, and the question then becomes one of, how do you respond to someone who is asking you as a practitioner or a clinician to do something or to implement an intervention that looks like it might be questionable? So I would love to get a trainee out of either probably psychology or medicine, I suspect, because you're most likely to get this sort of thing. Maybe the audiology and speech and language folks will also get it, but I'd love to get a trainee as a volunteer for this. We'll make it easy for you, Molly, but it is possible in your role as a practitioner or clinician that you may get someone coming to you and saying something like this, and I'm going to play the role of the mother. And your job is to respond to me. And you can see what I'm going to say right here, so it makes it a little bit easier. But I'm going to come in, I'm going to say, Molly, or Dr. Bilal, I saw this fantastic show on TV about advances in autism treatment. This show proved that the use of a special diet plus the placement of a stocking cap with magnets on a child's head can reprogram their brains and cure autism within months. I'd like to enroll Jeremiah in this therapy. What do you say, Molly?
So I'd want to know exactly what program you saw this on and the name of it so that I could research this on my own.
Okay. Well, I saw it on CNN. That's a reliable source, isn't it, Molly?
It can be.
Can we go ahead and proceed with this, Molly?
So I'd like to take some time to look into it to see the benefits and the risks, and then possibly next week we could come in for a follow-up and I could let you know what I think about this treatment. Okay,
great. Let me move us forward 1 week then, Molly, okay?
Okay.
I'm back again. You've looked at this and you go, I don't see any empirical support for this. I see people out there championing this because they're selling stocking caps and they're also selling this special diet. So I come back that next week and I say, okay, do you have a chance to look at it? What do we do now, Molly? I'd like to try it out with Jeremiah.
Right, so depending on my research, if I did not see any risk to Jeremiah, like there was no harm, I would say if you'd like to try this, it's something we can try, but I'd also like to continue the other avenues of treatment that we're currently using, because I do see improvement with those. But if you'd like to try this, as long as there's no harm to Jeremiah.
Great. And I like what you said, and in the interest of time, I'm going to make just a few comments. Normally I'd be asking, and by the way, thank you, Molly. That was very good, by the way. Normally I'd be going to the next slide and saying, okay, the rest of the trainees, you've got to give Molly a grade. And most importantly, be prepared to justify your grade. And you can be thinking about that at the moment, because what I would end up doing is coming back and saying, okay, why did you give Molly a B? Okay, somebody, why did you give her an A? Tell me that. And we'd be looking at ways to improve potentially what Molly had said. First of all, Molly, I think you did a really great job pointing out that I need to research this. I don't want to pass judgment before. And then you did another thing that I thought was really smart, Molly. You said we should probably continue with what works, number one, and number two, I might have a different response if I got any evidence that this diet or this magnet hat could be potentially damaging. So some of the things to think about as you're dealing with non-evidence-based treatments. Some of them are going to be untested. Some of them might be ineffective. And by the way, if you're putting all your time and resources into an ineffective treatment, think about this as being an opportunity cost. It may prevent you from pursuing more effective interventions. Some of them could be potentially harmful, where you have to consider about the risk. Then the other thing that I would only add to what Molly pointed out is this is a great place to emphasize your shared commitment to the well-being and non-harm of the client. To say something like, you know, like you, I'm interested in the best possible treatment and outcome for Jeremiah. And then follow that up with saying, and I think in my experience then, that doing and emphasizing interventions that look like they have been tested out is preferable to doing interventions that have not yet been tested and might prove to be harmful. I don't want to do anything that would harm Jeremiah. I don't think you do either. The other part is to emphasize your commitment to professional ethics. So that's just a very brief exercise. I'm sorry we didn't do the timing well enough to kind of get us through that well, but I would encourage all of you to begin thinking about not just intellectualizing about what you do, but to also practice how you would explain things and what you would say to clients under these conditions. Now, I know we're out of time. Let me just finish off with one other tiny little comment here, and that is let's link back to the Lynn values. And I'm going to point out that this is one side of a coin, really. And you're familiar with the Lynn values. The point that I'd like to make is that if you find the evidence-based practice concept fairly helpful and fairly persuasive, that there's also another side of this. Both sides are valuable, and the life values are critically important. The other side I'm going to call the 6 E's. I just made that up, forgive me, okay? But it also involves efficacy of treatment. Does treatment actually work? Efficiency of treatment. Can you get improvements in a timely fashion? Educational. Does it improve the person's knowledge base that you're working with so they succeed, for example, in school better and they move on in their life more effectively? Does it enable them in some way, shape, or form to have a job, to have relationships? Does it empower them to achieve their goals? Does it fall within your purview of what you think to be ethical? So I would encourage all of us to think not only about the life values, those are really critically important, but if you think about the evidence-based practice, to think about these other themes that would be helpful in terms of the way we think about the services we might provide in the neurodevelopmental disorders area. I apologize for running a few seconds long. I would certainly be happy to open the mic to see if there's any comments or questions, but recognize, of course, that people are probably ready to move on with other parts of their life. So any questions or comments as we're going on or as we're wrapping things up? Sorry to keep you a few minutes late. I hope some of what we talked about was helpful and that you can translate some of what we talked about into your own discipline. Have a fine evening, everybody. Thank you.